Okay. Cool. All right. I'll do a quick introduction and then I'll let you take it away. So, welcome everyone to our second webinar of the year. Um, Today we're really lucky. So we have Maria Renee. She's going to do a talk on WES and whole genome sequencing. Just kind of give us some updates, some cases, let us know what's going on. Just so that you guys know, if you did not see my post in the website group, that we're not going to be offering CEUs for the webinar series this year. Just some deadlines and things happened. So unfortunately, that's not happening. However, it is kind of a good thing because I think now we have some more freedom to like make this more conversational. So if you guys have questions or want to, just like have a conversation in the middle of this, definitely it can happen. So with that, I'm going to pass it over to Maria Renee. You can take it away. And yeah, I'm excited.
Awesome. Yes, and you can hear me okay. I apologize. I'm a little like congested today, so I'm going to be drinking and trying to not get to the point where I'm coughing all in your faces. So yeah, essentially this was prompted in that we were wanting to review some updated guidelines that ACMG put out in the last couple of years regarding exome sequencing. So I kind of took with that and ran with it a little bit in terms of what I thought might be helpful for us to even people not in pediatrics or to know kind of what's going on, where are we at, how are we using exome and genome sequencing, and thought I could pull a few cases that I thought were interesting so that we could kind of discuss that. I would love if people would chime in with questions as we went along or opinions or like, oh my God, that sounds crazy. Tell me more. Like this is meant to be very casual. And so that way we can kind of learn from each other. Because I like talking about myself and that I also don't have any colleagues here in Arizona. I'll share a little bit about me. So I've been a clinical genetic counselor at Genome Medical since 2019. I've been living in Arizona since 2019. 2018. Spent a hot second at Phoenix Children's Hospital where I met many lovely people who I think are not here. And so I live in the Northwest Valley. I just bought a house recently with my parents. And so part of that, my interests lately have been really trying my best at renovating and redecorating that house. And some of my work interests are actually exome and healthy screening and genome. So that's what part of the reason I was excited to talk about this today is that I've kind of inadvertently been thrown into learning about these offerings. I also have gotten really interested in EDS and have always had a passion for newborn screening. So that's a little bit about me. I do primarily see peds and rare disease adults at Genome Medical, where we're fully telemed, and nothing to like disclose or anything. So some of my goals today are to kind of talk specifically about new ACMG guidelines, talking about both kind of guidelines for how to use WES and also what some new secondary findings that have been added. Also talking a little bit about copy number variant detection with exome and genome, because I think that's been something new in the last few years. And then using some case examples that highlight all of these ideas about where we're at with exome today. And then at the end, familiarizing ourselves with some of the healthy screening options that are out there so that as if patients ever bring them up, you kind of know what the deal is with some of these tests. So kind of thinking about what we thought about with exome even just 3 to 5 years ago, essentially exome was almost like the last step. So you have a child with congenital anomalies, developmental delay, intellectual disability. Typically what we were doing in the past is a CMA, so chromosomal microarray and Fragile X, potentially after that doing other sort of symptom directed panels to evaluate for the genetic etiology. And then once you get all that done, you can kind of prove to insurance, like, can we please do an exome and kind of going from there. What is new now is that in 2021, ACMG put out a practice guideline essentially saying that exome and genome sequencing for people with congenital anomalies, intellectual disability, or delays could be considered in children as a first or second tier test. This slide is a little much, but essentially going step by step of like, this was their determination and their conclusion, a little bit of the why. So overall, the evidence that they were saying led them to this conclusion is that really getting a diagnosis can change the management guidelines and reduce some of that morbidity and mortality in patients and reducing the burden on patients and family. That's essentially why we do what we do in peds genetics. But that exome really has a higher diagnostic yield than other tests. And so that plus the fact that the benefits of this test are so big compared to how limited the harms are as compared to other testing options and going through that step-by-step route. There's also discussion of just some of the things we've been learning are that there is a lot of heterogeneity in these conditions. The more people we test, the more variability we see for a genetic disorder. And so that can lead to a variation in the timing of a diagnosis for an individual. Depending on what their symptom is, you maybe wouldn't have thought of a particular gene on a panel, but an exome may be able to find it. So that was one of their justifications. One of the things that they were able to pull together, which I think is interesting, is that is just the clinical management impact of exome sequencing and genome sequencing. Essentially, on average, they saw about in 8% of cases, there is a short-term impact on their clinical management, and then 10% long-term impact on clinical management for individuals undergoing exome sequencing. And that's really for, treatments and guidelines that way. The diagnostic yield, I didn't specifically say, we do quote around 30 to 40% for trio exome sequencing. So that's where you're doing the patient and their parents, or patient, a parent, and a sibling. For a proband only exome, we're typically quoting about 20%. And again, this varies. If you really want to get into the weeds, will vary based off of indication, but that's around what we're quoting. They did also highlight kind of how this testing should be done. So doing testing when a trio is available, doing it that way is really going to be your best bet. And then also should include pre-test counseling. They mentioned a bit about kind of rapid and ultra rapid should be considered based off of a clinical situation. And there are a lot of papers showing how impactful that can be in like a neonatal or kind of acute care setting, which I unfortunately didn't go into too much with this today, but they did kind of mention that that should be considered. They specifically did not discuss whether autism as a primary indication should be reason to do exome sequencing. And they also didn't discuss whether mitochondrial DNA should be done along with it, even though those are things that, there were guidelines in the past saying that exome should be considered in individuals with autism, but just not as a first tier test is usually the discussion. So that's a brief summary of just what these updated guidelines are. And with guidelines, some of this has already been done. It's not like we're changing practice that much with this, but the hope is, are we changing things like insurance coverage? And so this is where I don't know if there's any people who order exome on this call now, but wondering whether you guys have seen any changes on how this new guideline might impact insurance coverage. I looked at a couple of big insurers to see if they had exome guidelines. Essentially, Cigna was one that had an update this year where they didn't specify actually needing any other testing first. So you wonder whether that is partially based off of these guidelines, whereas something like a Blue Cross of California, which I see a lot of patients with, does require previous negative testing. And then of course there's random insurances that will just still not cover exome at all because it's thought of as experimental. And I think that is hopefully going by the wayside. But insurance response can be slow and it's so mixed, policy to policy even. So I don't know if anyone has any recent experience on exome coverage and whether that's changed in the last couple years. I'll sip, and then if no, I'll continue. The other interesting update has been the ACMG secondary findings list. For a long time, it was ACMG 59, the ACMG 59. Well, now we're at ACMG 72 because they've added more genes relating to some cancer disorders. If anyone wants to weigh in on their opinions on any of these, I'd be interested. Some cardiac conditions, things like biotinidase deficiency and Pompe disease that do have treatments available. Um, and then the rest are kind of HTT, no, sorry, HHT, hemochromatosis, but only homozygotes is what they recommended, which I think is helpful since there's a lot of hemochromatosis carriers out there. Um, and then a retinopathy, and then now I'm trying to remember what that other one is. Oh, it's a MODY gene there too. So just to kind of put that on your radar is that there are new genes that are potentially being reported as a secondary finding on exome sequencing. And that's always important to kind of highlight in your pretest counseling. I typically don't go through every gene, but a general idea can be helpful. Any thoughts or questions on that? And then I'll kind of continue with some of my case examples. I'll go with no. Okay. So to start us off, this is an interesting case to me because it was an adult woman who had had a history of developmental delay and cognitive disability or intellectual disability. She had been seen by genetics and had like a full workup, but it had actually been 20 years since she was last seen. And so she had a history of hypotonia, some feeding difficulties, developmental delay, autism, scoliosis, short stature. She had a previous negative karyotype and Fragile X, but kind of in the early 2000s just had reached an age where she was in her teens, there wasn't much else to do, and they kind of dropped off. So they came back to us at Genome Medical for testing, and we actually did elect to do an exome trio because their insurance was in a situation where they would cover it, which was great. And what we ended up finding was an ARID1B pathogenic mutation, which is associated with Coffin-Siris syndrome. This very much explained this woman's history and provided a clear diagnosis for this family. Nothing huge changed medical management wise. I'll be honest, she was already getting what she needed. But getting that diagnosis and connecting that family to a larger community was huge. And we actually had her sister present at a Genome Medical meeting to just kind of talk about that process for them. And I think this illustrates just how effective as a kind of first tier test this was. You could argue that maybe with a better eye for dysmorphology and a clinical exam, because we don't do clinical exams, you maybe could have caught the Coffin-Siris at the start with a smaller panel. But knowing this family and how much they wanted to do testing, I imagine that doing an exome would have maybe been where we ended up anyways, because there are kind of dual diagnoses, and she wasn't kind of a slam dunk for Coffin-Siris because her kind of dysmorphic features were not as dysmorphic, I guess, as someone else with Coffin-Siris. So I thought that this was a really helpful kind of one bang get your answer sort of case. And was, hugely helpful that we found a de novo mutation for their sister who was planning to have a family and wanted to know her risks. The second case I wanted to talk through was a teen that we saw who we saw through a partnership with a children's hospital. So essentially a children's hospital sends us patients they think would be appropriate to be seen by a GC first. And so we take a history and determine testing strategy. He had had a history of developmental delay, kyphosis, The only real family history was he did have a sister who died of a brain malformation. Mom could not give a ton more information about that. And he had had some negative genetic testing in the past. So he had a microarray done in 2011, Fragile X that was negative, and he even had like a pretty expanded X-linked intellectual disability panel that had two variants of uncertain significance that weren't really, hugely interesting. Um, I think his array could have been updated. Um, but instead we went with a trio exome because that's kind of what I like to do. So we ordered our trio exome and we actually did find a trisomy 18p, so an 18p duplication. Um, and that is associated with variable intellectual disability, and facial dysmorphism. We actually called the lab because it's a pretty sizable duplication, and we were pretty interested that his microarray had been negative in the past. Um, and with the exome, we also got to understand the VUSs a little more. And so one of them had been maternally inherited, and one actually wasn't able to be captured on exome. So still a little bit of a question mark, but I don't think it was super suspicious to us. Um, I think this was a good case that highlight some of these new exome capabilities. New in the sense that they're validated, and I'll talk a little bit more about that, is they're reporting out copy number variants much more. And so you're able to essentially get almost a microarray on exome sequencing, to get those deletions and duplications as a part while also ruling out, or at least, checking for other conditions. Um, this duplication is often seen as a translocation. So we discussed with the family whether we were going to do, blood testing for him, to do a karyotype, and to do FISH to test for um, mosaicism in him. But where he was at, he was not doing blood draws very well. And so we kind of counseled the family on discussing these results with people who are planning their families. So wanted to spend a little bit of time talking about copy number variant capture on exome sequencing, because that has often been a limitation that's been discussed on sequencing, is it's not really great at doing deletions and duplications. There's still some limitations, and I think the most important thing is that this varies greatly lab to lab. So knowing what lab you're using and whether they are able to detect copy number variants on their platform is very important, because exomes are not the same lab to lab. But about most labs who are doing exome and boast the ability to do copy number detection will do maybe 5 exons or more in terms of their ability to detect copy number variants. So you do have a gap of a few base pairs to up to 3 to 5 exons where you're really not getting great ability to detect that. So there's a little bit of a gap there. And of course, in genes that are more complex and have different pseudo gene regions, you may not be able to detect that. But that's one of the reasons we can kind of justify skipping that microarray step and going straight to exome on these kids, because we are able to find these copy number variants now. And again, this for me, at least practice wise, is something that's changed from when I started 6 years ago to now. Let me take a sip. So case 3 is essentially a case to highlight why this having knowledge of what secondary findings are on exome is helpful. So this was a 2-year-old male, or almost 2 years old when I saw him, who was conceived via IVF because the parents had done PGD for a known BRCA2 mutation in the mother. They had a pretty good workup. They had negative carrier testing, ready to go. And then their sweet little boy was very premature. I believe it was like in the 20 weeks. And so he had a lot of health complications from that. But on top of that, had kind of more delay and more growth issues than I think that they were expecting, correcting for that prematurity. He also had this aberrant, which I always say wrong, right subclavian artery. And some brain imaging that was abnormal that they were still kind of working up when I saw him. Because of the kind of variety of his features, we again went straight to exome. I promise I don't do exome on everyone, but um, and so when we did that, he actually came back with a couple VUSs and a gene that kind of fit, kind of didn't. Um, but what he also had was an FBN1 likely pathogenic mutation, and that's associated with Marfan syndrome. Um, that mutation was inherited from his dad, who was completely unaffected, completely confused by these results and what they meant for them. Luckily, we had kind of had a pretty decent conversation about secondary findings on the pretest because of their knowledge of kind of hereditary diseases like BRCA that they're somewhat prepared for this possibility, but obviously with the extent they went with their prenatal and family planning, this was a huge shock and a tough one to swallow and really understand. I mean, essentially we're learning a lot about FBN1 and it may be more variable, but still kind of recommending seeing a cardiologist for dad and for the son and having ophthalmology exams to make sure all of that was in a row and hopefully following up with them within a year or so to kind of re-review all of this. The RECQL4 is associated with some various conditions, all have kind of growth delays, but they also have other symptoms that didn't really fit him. And, even though we understood the inheritance and everything, this one is still kind of up in the air in terms of whether it's really an explanation for him. And so the plan is to do a reanalysis of that data in a year or two to see, if we can understand it a little better. And a lot of labs offer that for free. So that's a helpful thing to be able to do, is kind of not rerun a sample, but kind of go back and look at all of the data again to see if there's any new genes or new understanding of variants that we wouldn't have had in the past. And then this is my last case to talk through. This is a really tough case because this was a case seen by a different genetic counselor first and then came to us. And this will introduce a few different things that we'll talk later on. But essentially, this family was seen by us at Genome Medical because they had a newborn daughter who they wanted to order whole genome sequencing on, like a healthy screening whole genome sequencing, because they wanted to see whether the daughter would have a risk for autism like her brother, who was recently diagnosed with autism. They were doing cord blood banking, and this was offered as an addition to that. And so they were very interested in this testing. Luckily, they do have to see a genetic counselor to get that done. And so in that process, the genetic counselor who saw them said, hey, well, let's actually do exome on her brother to figure out whether there is a diagnosis we can more better understand in the family. They ordered a proband only exome, so only did the whole exome sequencing on the little brother. And they did find a likely pathogenic mutation in the TCF12 gene. This gene, if we had gone back to all our like boards days, would be one that you think about with craniosynostosis and Shea3-Chotzen syndrome. Not really one you think of in a child with isolated autism. But new papers and studies are showing families where you can have kind of just an isolated neurodevelopmental disorder, and there's also a lot of reduced penetrance. So a very messy result, especially without having parents done at the same time. So I saw them on the results end of things, and just it was tough because we're essentially now asking them to pay out of pocket to do the parental testing. It's difficult as predictive testing because it is reduced penetrance, and so that is kind of a complex discussion. I think this does a good job of highlighting the genetic heterogeneity that ACMG paper was mentioning, and that we're learning so much about these conditions. This gene, I looked back and thought, okay, what else would I have done for this kid? I maybe would have thought about a neurodevelopmental disorder panel, because that's going to cover most of the things that are associated with like an isolated autism and delays case. And actually wouldn't have been on that panel because, again, this is really thought of as more of a craniosynostosis gene, and that needs to catch up. Something like exome that's looking at everything or at least a lot of things, is more likely to find something like this that is more variable. And so I thought this was a good case to highlight that a little bit. That had we kind of ended with a neurodevelopmental panel, they maybe wouldn't have gotten a clear answer for what we think is likely an explanation for this child's picture. I'm still waiting on that parental testing to come back on that. So kind of moving away from how we typically think about exome sequencing, and talking a little bit about what is out there that people are maybe encountering outside of the world of rare disease, and that's some screening, healthy screening options. So I have gotten Facebook ads for this. I don't know if anyone else has as well, but essentially there are labs out there, and obviously this is none of this is an ad for these labs. I just want you to be familiar with some of the names. Think people like Nebula and Dante and kind of the sequencing lab are offering really low cost genome sequencing, in the like $300 range off of buccal swabs. They're doing it at like 30x read depth. To put that in context, typically for kind of clinical testing for a bigger lab that we use in rare disease, you're thinking like 100 plus read depth. So kind of a quick and easy genome where typically all you're getting for that $300 price is the raw data. What you can then add on afterwards are things like ancestry information, or things like they'll boast like nutrition profiles. They'll even say that you can test for some actionable genes like the ACMG59. I'm just less familiar with what those results look like on the back end, but I have had patients who have ordered this hoping to evaluate for symptoms that they've had. And sometimes what they'll do as well is take this data and plug it into something like Prometheus, which is spitting out a bunch of variants. And it can be very difficult to wade through, what is a pathogenic variant, what's benign, what's a VUS. And so sometimes patients have encountered that. To be perfectly honest, we do see patients risk. We do not analyze raw data. But if they're concerned about a particular variant, we help them access clinical out of pocket, testing for that so that they can get that confirmed. It's sometimes if you've paid for a report through some of these, they're accurate. But through Prometheus and things, it can be really hit or miss. So just exposing you all a little bit to what's out there that's direct to consumer. What's tough also is that you pay for the testing before you get your kit. So I think for one of them, there's like a 3-hour window where you can get your money back if you decide you don't want to do it. But once you get your kit and you pay for it, it's done. Now, what's very different from that direct to consumer testing is the world of kind of whole genome and exome healthy screening options. Essentially, many labs, as you can see up here, are starting to do this for varying prices. The cheapest is around $1,900, and then it can go up a lot more from there. Typically, what that's doing is doing whole genome sequencing, but each lab has kind of their proprietary list of genes that they will report on if they see a pathogenic variant. It's usually pathogenic or likely pathogenic. They'll also report on carrier status. Some will give some pharmacogenomic information. Some will even evaluate for some repeat disorders. And then you can also get your raw data. I see a good amount of people for this, people who have money to kind of spend and just say, hey, I recognize that they're doing an assessment and saying there doesn't really seem to be a very high risk for hereditary disease, but we can go ahead and do a whole genome that looks at quote unquote everything to make sure there's nothing that would alter your path from being on kind of that general population guidelines that wouldn't be present in your family history. So maybe many adoptees or people with limited family history information will kind of pursue these options. Typically, these are being done in adults, but I imagine anyone in the prenatal space has some familiarity with Viacord, and um, you can actually get a uh, pediatric version of this test where they essentially filter towards childhood onset only results. Um, it's an interesting area, but it's happening, and so just wanting to kind of let you guys know that this is a world that patients may be experiencing or getting some results on, and they're not all just like the other direct to consumer ones. They are getting clinical information here. I really had. I would love to hear any questions or thoughts, or if there was anything I needed to clarify.
Hi, Maria Renee. Thank you so much for giving us your insight. As someone who's like outside of the peds clinic for so long, um, do you see this like exomes and genomes maybe even replacing the need for like a formal genetics physical evaluation and maybe, alleviating some of the lack of geneticists that we see and maybe a role for GCs to kind of order that testing before even a physical?
Yeah, I mean, I very much think that, because that's my all we do. So we are typically going with a genetic counselor only assessment, and then getting testing, and then if needed sending back to genetics, or if there's still question marks there, going towards that physical exam as being the second step. um, I think it's very doable. Oh, we did an abstract, I think last year at NSGC, kind of showing how we can alleviate some of that burden on the pediatric genetics system. Um, because we are able to see a lot of kids without that physical exam, and ordering testing that will at least get us a few steps in. So that's sometimes what I tell families of kids who are really complex, where I start to go, ugh, this is a little much for me to just do based off of parent report. Hey, get on that wait list for genetics in whatever city you're in. Hey, if I can have you walk in with an exome, even if it's a negative exome, then that's going to help them. So I think I'm very passionate about that being something that can help. But I think it takes knowing your limits as a genetic counselor too, to be able to say, like, this is outside of the scope of my ability to understand it. Um, yeah. I'm sharing too.
I have another question too, I guess.
Yeah, go for it.
As someone who worked with a company that was doing genomes for, a quick second, I guess, where do you see the complexities being? I know some of these, when they're starting to do some more of the long read sequencing and doing some of the triplet repeats, what are your thoughts, I guess, on the can of worms this might open of, are we going to identify like an HD mutation and the consenting that kind of goes along with some of these testing?
Yeah, I think what we can find is a really tough thing, and that's why I think the counseling aspect. I think that's why I find it so interesting, because I don't know too much about repeat disorders and kind of the technical aspects of this, but in terms of the counseling aspect, um, patients who are seeking healthy screening options have no idea what those results can look like. Um, I think many people think that it's going to be directive in terms of the nitty gritty of their healthcare. So people will get a negative result and say, "What the heck? I just spent all this money and my result is negative." And that's most people. They're going to get a negative result because most people do not have a hereditary condition, um, and they want, what food should I eat? Those kind of things that are offered direct to consumer, that that aren't really kind of actionable in the way that we would like them to be for clinical testing. Then the other side of more what you're talking about is, what happens when one of these comes back unexpectedly. And in theory, all of the results that come back on healthy screening in genome are unexpected, because had they been flagged as a concern on the front end, we would have done that targeted testing, swayed away from healthy screening and gone towards something more diagnostic. Um, and something that I don't have an answer to how to handle this, but I will talk about just some experiences I've had. Um, Patients who are being very critical, thinking about kind of what those possible results could be, want a gene list. They want a list of conditions that they're going to be tested for, to either be able to prepare for what if that comes back, or to, on the back end, be able to tick off and say, oh, cool, I know I don't have Huntington's disease. I know I don't have hereditary cancer. And that's also not the point of healthy screening, since we are only reporting out, the labs are only reporting out path and likely paths. It's not diagnostic. And those intricacies are really, really tough. And I don't think I have a great answer beyond being able to somewhat concisely give an idea of what types of conditions could come back, that essentially, yeah, there may be results that come back that allow you to be proactive, but there may also be results where you get a diagnosis and there's nothing to do. And so that's typically where we land on, is which one of those two, if either, are you comfortable with? And if anyone is uncomfortable with the idea of getting something back that's not actionable, that's where we maybe, where they maybe would take a step back. But in terms of like the same way we do pre-symptomatic testing for HD, where we're recommending a site consult and things like that, there's no regulation for HD testing that way either. It's more practice-based, but there's no extra steps there. So it's definitely messy with these labs that are doing repeat expansions.
So Maria, Renee, can you hear me? This is Sarah Fox. So when you're talking about this healthy screening and they come back with some sort of abnormality, do they have to then get it confirmed someplace else? I mean, I'm hearing that in your voice, but it really is diagnostic, isn't it?
It's diagnostic, yeah. Okay. I mean, it is. They are clinical labs doing the testing. So typically, no. So the cord blood one, so the testing they do for ViaCord, which I mentioned specifically just because that's the one that does the pediatric testing, they are doing it on cord blood. And so sometimes we do offer confirmatory testing for that, because of that very small possibility there's a discordance there, but we've yet to come back with anything that disproves that initial result, and the lab is pretty confident about it. So these are clinical diagnostic, they're not diagnostic tests, but healthy screening tests.
Okay, and then I have another follow-up question, well, two really. So from your experience, and I know you work mostly in peds and adults, but from your experience, how many places are doing, whole exome sequencing prenatally? That's number one. And well, answer that one first. So,
I don't have a great answer for that, to be honest, Sarah. It's definitely not a world that I am in at all, and so I should have looked at that, but I didn't.
Well,
I guess
does anybody else on the call have an idea of what the percentage of these prenatal places that are now utilizing going right to WES? Anybody? I just got my first approved, so I was excited about that.
Oh, wow.
But nobody?
Can I ask why you went towards prenatal WES for that case? I just have no experience.
Yeah, that was interesting because it was kind of driven by insurance, to be honest with you. It was a case that, and it goes back to understanding the limitations of all this kind of testing, no matter what it is. This was a couple that had PGTA for IVF, so we're told that they had a normal female, and I had looked at the results and they had 5 embryos, 2 were normal female, the other 2 had some weird chromosome things, including like a 1q deletion, stuff like that. So they made it in pregnancy. They then had non-invasive prenatal screening, which was negative, and then felt they were, good to go because that's what everybody told them, and show up here at 23 weeks with club feet and, well, what looked like, arthrogryposis. So we were like, okay, there's a lot of genes now associated with arthrogryposis, and let's, maybe do an amnio, because they were trying to decide whether they wanted to terminate or not, and they were getting really close to the cutoff, right? So they ended up doing an amnio, which I did just, I'm always going to do a CMA right now on that. And I tried to get off to do an arthrogryposis panel at GeneDx. It has 27 genes on it, and their insurance, Blue Cross Blue Shield, will only pay for panels that are 4 or less.
Okay.
And I'm like, okay, that is really stupid, but that was one. And then I'm like, okay, so why don't we see if we can get WES? And I happened to go out for dinner with a bunch of genetic counselors, and we were talking about it. And so I did, and I got approval for it. And in the meantime, which I'm still interested in doing the WES on this family, but in the meantime, the CMA came back with a 4q25 deletion of 1.76, megabases deletion. So the family was like, this isn't my embryo, because we had PGTA.
Right.
And I'm like, okay, so I even double checked with the lab that did it, and they can only find deletions, maybe as low as, as small as 10 megabases. So this was a micro deletion and still significant. But the weird thing is, this particular micro deletion is not associated with arthrogryposis. It's associated with Axenfeld-Rieger syndrome and, eye things. And, that wasn't even on our radar. So we're going to WES to see if there's going to be anything else. And they ended up terminating the pregnancy, but they just want to know. And the weird thing is, one of their biggest things is they want to know if this embryo was theirs. And although I haven't sent off their blood, we probably, will do it as a trio eventually. But where I'm sending it, it's cheaper to do it on the back end. And but the main reason they want to do that is to see if that embryo truly was theirs, which it really was. They just don't understand the limitations of the PGTA testing.
Right. That's really interesting.
Yeah. And there was another question I had, but I can't now remember what it was.
Well, Sarah, I'm curious now, so I'll ask our repro team, what their experience is, and if I get anything wildly interesting, I'll let you know.
I would appreciate that, because, I've only been back in prenatal since July, and it's, learning the world and trying to figure out the best things to do. But in the CMA has been a pretty good detective for us so far, but there's going to be those unusual cases where it just doesn't give you an answer. So, or products of conception too.
Right.
Any other questions for Maria Renee? Okay. Well, thank you so much. That was super, super interesting. And this is recorded, so I'm going to post it on the website just like I always do. That way people who missed out can definitely watch and take part. Otherwise, our next webinar is TBD. It's going to be on mentorship just a little bit later in the year, probably Q3. But thank you guys all so much for coming. And again, thank you, Maria Renee, just for all of your knowledge. It's really, really valuable. Cool. All right. Any other last minute comments, concerns, questions, anything? Cool. All right. Well, thank you guys. We'll see you next time.
Hi, thank you.
Bye.